Hello and welcome to STANA Sensory Insights series. I'm Katie Boateng, President and a founding board member of the Smell and Taste Association of North America and a person living with acquired anosmia. In recognition of Anosmia Awareness Day 2026, we are honored to feature a special conversation with leading rhinologist and researcher, Dr. Pinto. Dr. Pinto is a nationally recognized expert in olfactory disorders and a member of the steering committee for the Sense Network, which is a collaborative research initiative working to support research on the role of sensory functioning. At STANA, our mission is to elevate sensory health as essential to overall health and wellness, and to ensure that the voices and lived experiences of patients are included in research, clinical care, and public awareness. Today's conversation is designed to provide clear, accessible, evidence-based information for people who are living with smell loss, those who care about them, and clinicians who are interested in learning more as well. So, Dr. Pinto, thank you so much for joining us.
Thank you. Thank you so much for having me. I'm very happy to be here.
Awesome. So, to start, could you briefly introduce yourself and what led you to become an ENT and then to specialize in rhinology and your interest in smell disorders?
Sure. So, I am a professor of otolaryngology here at the University of Chicago. I went to college and medical school at Stanford University, and then I came here to the University of Chicago for training in otolaryngology and rhinology. During that time, let me back up. So I decided to go to ENT because of the big impact the problems in the ear, nose, and throat have on people. In particular, the ability to communicate. So things like hearing, things like speech, things like how your face looks, and things how your sensory function operates, like your sense of smell and breathing. So I became very interested in how these things would affect people's lives, and I think they are fundamental to people's lives. When I did my training at the University of Chicago, I spent 2 years on a um, funded research program called a T32, which gives dedicated time to train people in research. And I spent some time looking for genes involved in smell loss. So I became interested. This was around the time of the Human Genome Project.
Oh,
There was
cool.
this big idea that, like, hey, we can find genes that are causing complicated problems. I had a wonderful mentor named Carol Ober, who I still work with in genetics, and she was looking for genes in asthma. So I started to look for genes for sinusitis. And one of the things we looked at was sense of smell in that context. So could we test the sense of smell in people and find genes involved in smell function and smell dysfunction? That proved to be a lot more complicated, as we've learned over time that finding genes for complex problems is not as easy as we had maybe hoped for. I did find some evidence for some genetic variation that predisposes to smell problems. And that sort of kicked off my interest in saying, we really don't know a lot about the sense of smell. We know a lot about hearing, we know a lot about vision, and smell problems we don't know so much about. And so I became very intrigued with the fact that we had this really important sense that affects us every day, every minute of our lives. And we really didn't know a lot about it, and we really didn't know how it declines. And so I began to look at that in a bigger context in my research. But maybe I'll stop there.
No, that's a great response. Thank you. So, speaking of your training, many people who experience smell dysfunction typically go to like a primary care provider first, and then probably are referred on to an ear, nose, and throat specialist or an otolaryngologist. What is the difference between a general ENT and a rhinologist? Can you kind of explain that a little bit further in the training involved? And then when should someone consider that type of specialty care, like going to a rhinologist?
Sure. So the training in ear, nose, and throat, general ear, nose, and throat, or otolaryngology head and neck surgery, is currently a 5-year training program. So there's 1 year, what we call an internship, where you do some different rotations in some general fields that are related to ENT. And then for 4 years after that, you do training in ear, nose, and throat. Now that training is the full spectrum of our specialty. which includes training in cancer of the head and neck and surgery and medicine of the ear and facial plastic surgery and surgery of the nose and sinuses and medical care of the nose and pediatrics and voice and sleep. So it's a wide spectrum, and people after that training can take care of all of those problems actually. And most otolaryngologists are in practices where they take care of the full suite of problems in adults and children, in sick people and healthy people, in people in the hospital, and people in the clinic, and both medicine and surgery. And so that's always a good place to start because many of the reason why we have an integrated field is the anatomy and the physiology of the head and neck is all connected.
Hmm.
There are many physiologic connections between these different systems, and so you want to have training in all those parts. People who want to do additional training in more complicated parts of ENT can then go on to what we call a fellowship, where you get specialized advanced training in the most complicated things in those fields. And some of those areas I mentioned before, but I'll focus here on rhinology. So rhinology is one what we call subspecialty or fellowship where you can do extra training in disease of the nose and the sinuses. And during that period, which can be, say, 1 or 2 years, depending, you focus on that area of ENT and you learn advanced techniques in both medical treatment and surgery of that area. So that might be, for example, in surgery, it might be tumors of the skull base. It might be surgery of the orbit through the nose. It might be cancer of the nose that's very advanced, where you would learn how to take care of those very complicated areas. Another thing you are an expert in when you're a rhinologist is medical diseases of the nose and sinuses and how the nose and sinuses work. Because obviously we treat a lot of things with medicines, and also how we do surgery is affected by how the anatomy and the nerves work together. And so you do get extra training in how the nose works, including in the olfactory area. So training in how olfaction works and what the treatments are for problems with olfaction. The one problem we face in the smell disorders field is, first of all, that not everybody is aware of the complexities of this problem. I think COVID has helped us now because many more people have it, unfortunately, but at least there's more awareness of it. And this is true in general practice, but even in general ear, nose, and throat, and certainly in rhinology. And then the other problem is we don't have enough rhinologists. So we would love to have rhinologists everywhere, in every place, in every city. But there is some limitation in the numbers of people who do that advanced training. There is some maldistribution of that. So, for example, if you live in a big city, there's probably lots of rhinologists.
Yeah.
If you live in a smaller city or in a rural area or in different parts of the country, it's less so. And so having access to the specialists who might have a little bit extra training in diseases of the nose and sinuses, surgery of the nose and sinuses, is not equitable across our population.
Yeah, that's definitely a problem. I'm from Idaho, and so the Rhinologic Society has a Find a Rhinologist tool. I typed in Idaho just because I was curious, and there's only one registered rhinologist in the state of Idaho on that website. I'm sure that there's more than one rhinologist in the entire state, but only one is listed in the directory. So I was like, there you go. That just shows you that
Yeah,
it,
I have, even in my lifetime of training, I know of colleagues who they were the first rhinologist, fellowship trained rhinologist in their medical center, or they were the first rhinologist in the state when they moved there to
yeah,
provide that kind of advanced care to more people. So yeah, that's not a surprising fact for Idaho.
yeah. So as a clinician who's seeing patients and working with these types of people, what are the most common causes of smell loss that you see today?
Yeah, so I try to sort of think about smell loss very simply. It's very complicated. There can be a lot of different causes of smell loss, more rare ones. But I would say the big four buckets that I start with any patient are um, the first is age, so age-related smell loss, and this is what I study actually in particular. Excuse me. So age-related smell loss. That's usually gradual. That's obviously in older people. Now there can be some different onset and some different trajectories and can manifest in different ways, but it is by far the most common. And that's because unlike some of the other things that are more acquired, this is something that is associated with aging. Just like vision decreases with age, hearing decreases with age, smell decreases with age. The other senses, other senses like taste and touch and other and balance decrease with age. And um, I think we can argue about like, what quote unquote normal aging is and what is aging and what is disease. And that's a big topic in the field of aging of like, what do we think of just as physiologic? And actually there's quite a lot of people working on reversing aging or slowing aging. And I'm hopeful that over time that will uh, hopefully even slow olfactory aging or neurologic aging, which obviously we're all interested in. So
Mhm.
age is a big one. A second is inflammatory disease. So things like nasal polyposis, chronic sinusitis, even allergic rhinitis to some degree can affect your sense of smell. This is where the lining of the nose is irritated and immune cells come into the nose. In the case of polyps, they can grow polyps, which can block the olfactory cleft and physically block smells. But even the inflammation itself from the polyps can affect the functioning of the nerve. And so any inflammatory disease of the nose can cause problems with the sense of smell. That's one that is well within the domain of a general ENT who has really good training in that, and certainly of a rhinologist who thinks about that a lot, has really good treatments for that, and those include surgery and medicine of different kinds. Um, and I would say we have the most success with that actually, because
Mm.
we have treatments for inflammation, both surgery and medicine, and so if we can reverse inflammation, we can improve the sense of smell. And I think that also has some hope for other forms of smell loss because we know that inflammation is a trigger. And so we know that, inflammation is one potential pathway that might affect other forms of smell loss. Number three is trauma. This is usually pretty obvious. I was in a car accident. I injured my head. I have what's called a coup contra coup injury, where you hit something and then your head goes back,
Mm.
and that shears the olfactory phyla, the tiny little olfactory neurons that go through the holes in the skull base and get into your nose. So that's usually relatively obvious and has a pretty clear history. And then finally, viral smell loss. So
Mm.
obviously, SARS coronavirus 2 is the first and most clearly identified virus that causes sense of smell problems. But there are other viruses also that can cause smell law problems. And that typically is I had a really bad cold, a really bad virus. I recovered. My smell was gone during the cold, but unlike other colds, it did not recover afterwards. And sometimes it delays care because people think, well, it's going to come back, it's going to come back, and 6 months goes by, and they don't realize that it's been injured.
Mhm.
One thing that's been good about COVID is now people realize, oh, it could be injured from the virus, and I can
Mhm.
seek care earlier. And I think that's going to help us move the field forward because we can see people earlier, we can intervene earlier, and we can study people earlier while we have a chance of potentially reversing that problem. So viral smell loss is the other one.
Yeah.
I'm leaving out a host of other more rare causes. Tumors are very rare, metabolic problems, hormonal problems. There are other causes, but I would say those four are the big four that I sort of start with because those are affect most people.
Yeah, absolutely. Thank you for sharing that. Mine is the fourth one that you talked about. It was a bad upper respiratory infection over 4 or 5 weeks, and then, like you said, I didn't notice that it wasn't there for a while actually, and then I thought to myself, when is the last time I smelled something? I actually don't remember because when you're sick, you're not smelling or your food tastes off, all those types of things. So I definitely, and that was way before COVID happened. So it's viral for me. So I'm curious, When someone presents to your office, what does a thorough evaluation for smell loss actually entail? Like, is there a playbook that you go through to kind of rule out things? What does that look like?
Yeah, sure. Well, I think the first thing and I think about is just really getting a good history. So getting a good timeline, getting an idea of are there triggers that may have triggered this, like a cold or a virus, or are there exposures that could be causing this, like pollution, like allergens, like something in the environment. There's a host of occupational risk factors for smell loss, like exposure to chemicals or heavy metals or things like that. So I think about that. I work here at the University of Chicago. We're close to steel mills. We're close to heavy industry, so that's potentially a concern. Um, I also, and then, we mentioned things like history of inflammatory disease, history of sinus problems, history of allergies, family history of those things, right? A genetic predisposition. Can there be drivers why someone might have inflammation in their nose and be affecting their sense of smell? I think quite a lot about other exposures in the home. Again, just to think about other things that could be affecting the nose and hobbies that might be affecting that, unusual animals, pottery,
Mm,
chemicals, woodworking, things that might be affecting both the nose for inflammation and then also the nose and the brain for nerve function, right? Because those can be risk factors. I also get a good history about other neurologic problems. One thing we didn't talk about yet is that the olfactory system is closely connected to brain function
mm,
and related to aging. Maybe not so much for the other three causes, but for aging, seems to be a precursor of problems with the brain, specifically Alzheimer's and dementia, also Parkinson's disease. So I do get a neurologic history. Just to say, are you having any other neurologic problems? Could this be a sign of some other brain-related problem? We think about the olfactory system as what's going on in the nose and the periphery, what is providing the input. But then that nerve is connected straight into the brain. So there's also the brain, or what we call the central component or central olfactory processing. And so I want to screen for that too.
mm,
Usually, I will say that that is normal and not a cause. And so I'm not always thinking about that, up front. But if there are signs of that, that does trigger things like imaging of the brain to look for structural problems in the brain. And certainly anybody who has some neurologic symptoms along with olfactory loss, I would do that. In terms of the examination, a full head and neck examination, which involves cranial nerve function and certainly a nasal endoscopy. And that's where a special fiber optic camera is placed into the nose, and we look for any inflammatory disease in the nose, any anatomic variation in the nose that might be causing smell loss. And I also look myself in the olfactory cleft. So that is the space in between the turbinates and the roof of the nose, where the olfactory nerve sits and where the olfactory information comes in. Because certainly if there's inflammation there, if there's tumors there, if that's anatomically abnormal, I want to know that as a potential cause.
mm,
I do smell testing, objective smell testing. It turns out if you ask people how your sense of smell is, they're not good at determining that.
mhm.
If I ask you how fast you can run, you have some measures of like, okay, well, my friend's an athlete, he's an Olympic runner. I can't run as fast as him, but my other friend, I'm faster than that person, but you really have no reference for how good your sense of smell is, and so it's
Right.
difficult. And so objective testing is very helpful. It's also helpful because we can compare you with other people, right? So I can
Mhm.
say, here you are, here's your score, here's how you compare with other people in your sex and age range. And that way we can give a percentile of, say, I'm in the 90th percentile, I'm better than most people, or I'm in the fifth percentile, I'm not as good as most people. Or even I'm below the fifth percentile, or really where I'm essentially anosmic or have no sense of smell. So objective smell testing is really critical, I think. And it's really helpful For patients, it validates that they do have a problem or that they don't have a problem. Their sense of smell is good. It also gives us a reference. So if I tell you, here, your smell score is this today, I can do an intervention. I can see where are you in 6 months, where are you in 1 year, and that trajectory is very helpful
Hmm.
in letting patients know how they're doing, and also for monitoring for response and improvement. So smell testing really important. And then lastly, imaging can be helpful. It's not always necessary. Clearly, if you have a pretty good history, you may not need it, but it does show the anatomy of the nose and sinuses, especially for inflammatory disease, for which we have lots of treatments. When indicated, imaging of the brain is helpful, but again, usually not helpful unless there's some trigger, neurologic symptoms, or some unusual feature that makes you suspect a problem in the brain with the olfactory nerve. Um, Now, I will mention, and we didn't talk about something called idiopathic smell loss.
Hmm.
Someone comes in and says, I didn't have a cold, I didn't have trauma, I didn't have a virus, I don't have any inflammation, I'm perfectly healthy, but one day my sense of smell I noticed wasn't there or was gone. In those cases, I'm a little more inclined to do imaging
Mm.
because we don't have a reason, right? When you don't have
Right.
a reason, then you have to think about, well, am I missing something? And so then I have a little bit lower threshold to do some imaging in that case. But for me, for my practice, that's the workup. I'd say most of the other olfactory people, olfactory experts that I work with in research and in the Chemosensory Society or in other academic partnerships do very similar workup.
Yeah, that makes a lot of sense. It's interesting, because as far as I know, is there a clinical practice guideline from the American Academy of Otolaryngology, Head and Neck Surgery about how to treat someone who presents with smell dysfunction?
Not as far as I'm aware. Now, it might be embarrassing that I don't know about it, but not as far as I'm aware.
I
And
don't think it's embarrassing. I don't think that it's there the last
yeah,
time that we had looked into that. So that's something that would be great in the future to have like a clinical practice guideline published by that body so that all ENTs would follow that same path. Because I don't know that they do currently. My experience when I went to ENT and then neurologist is I was not ever provided with an objective smell test. They believed me when I told them that I couldn't smell, but I didn't actually get it tested. And so to me, that's kind of fascinating because, like, if I went to the doctor for my eyes, I would be given a vision exam. That would happen. And so it's curious that it currently doesn't. And I know that sometimes a big factor in that is insurance, right? I don't think that insurance covers a lot of these smell tests for ENTs and other clinicians. So, this is a curveball question, throwing this out there for you. What do you think it would take to get like preventative smell testing or like regular examination smell testing covered by insurance? What would it take for
yeah,
us to get there?
yeah. So this was a topic at one of the meetings, several meetings I've been to, that people are thinking about this really hard
Yep,
because we have this problem where we have hearing tests. You can get it almost anywhere. You have vision tests. You can get it almost everywhere. And we don't have widely available smell testing. And one of the reasons is we do not have a code. I mean, this
right,
is as bureaucratic as it gets. We do not have a code for a smell test. And when you don't have a code, you can't do anything in healthcare, which is,
right.
another issue. So part of it is convincing the agencies that control that to assign a code for a smell test, and validate the need for this kind of testing. Now, I think COVID has put a little bit of an impetus there to say, hey, we've got this thing, and you made smell loss a cardinal feature of diagnosing COVID. Well, guess what? Like, it would be helpful if we could actually test for that.
And
Um,
be reimbursed.
and
Yeah.
being reimbursed for that. I think so. I think getting a code and convincing insurance companies that this is worthwhile. I think we have to think about starting with the government, where we have a little more leverage,
Mm,
where clinicians have more leverage and patients have more leverage. And organizations like STANA would be great to lobby, for example, Medicare to say, hey, we want you to pay for this. This affects older
right.
people, and you can start with older people. And once the government has a code and covers it, then private insurance tends to follow. I think the NIH did a pretty good job of catalyzing new smell tests. So they had a
Yes.
initiative to develop new smell tests that were cheaper, that were easier, that were faster, that could be done with an online component. And those are in various stages of being kind of distributed and commercialized and being
Yep.
available. So I'm hopeful that that initiative actually will gain some traction, and in partnership with getting codes and reimbursement would be helpful. It really takes a community to do that, though. It takes patients, it takes
Yep.
doctors, um, and, and we have to sort of, kind of go with our pitchforks and say, hey, we want this, we need this, we got to have it.
I'll
And
join you.
I
I'll
think
be there.
I think we'll get there.
Yeah, absolutely. So I want to kind of change gears a little bit. And I know that you mentioned there's so many different causations for smell dysfunction. And so it's really difficult to say like, hey, what's the treatment for anosmia? Because what kind of anosmia, right? So I'm just curious, is there any research that's currently happening out in the world that you're really excited about for some treatments for anosmia, or what research would you want to pursue for treating certain types of anosmia?
Yeah. So I think a couple of things. I am extremely optimistic at this point. I've been working on this problem for a long time, and it was a sort of obscure corner of clinical research or even basic science research where, really people didn't understand the impact. People didn't understand how important it was, and it wasn't in everyday kind of parlance. Even among researchers or clinicians, you'd say, "Oh, I work on the sense of smell," and they wouldn't really know what you're talking about. Now it's in people's consciousness, which is great. And because, again, it's sort of a blessing and a curse, COVID was horrible for all of us and all the people who have suffered all the different things, including smell loss and even long smell loss, long-standing smell loss or permanent smell loss. At least it has finally kind of woken up the public and the government and the scientific agencies to the fact that, hey, we have ignored this, or under invested in research in the sense of smell, and we need to rectify that.
Right.
And I think the NIDCD is now like a little more reinvigorated and
Yep.
now pursuing a little more clinical research, whereas before they were pursuing a little more basic research.
Hmm.
And even other agencies like the National Institute on Aging and other places are now thinking, and the NINDS is now thinking like, okay, what about the sense of smell? How can we pull that in and kind of incorporate that into clinical research? So I am optimistic, which is number one. Number two, I think there's a lot of things we've learned, in recent research that really can be translated to clinical intervention. So for one, we have learned a lot about stem cell biology. The olfactory nerve has stem cells. We are now understand a little bit more how those stem cells and support cells operate in humans. And we now have the potential to manipulate that as a way of regenerating damage to the olfactory nerve. And I think that's quite exciting. Now,
That is, yeah.
though I think those therapies are pretty early, and I think we have a ways to go. But what I'm excited about is people understand that that is an opportunity to translate into clinical practice. I think
Mhm.
previous work on this field in animal models was like, this is great and it's super interesting in animals, and we will never get to humans. And now people are like, oh, we have to get to humans, and there is some work in human olfactory biology. So that is probably the thing I'm most excited about because I think we understand that acquired smell loss is damage to the olfactory nerve in the nose for the most part.
Right.
So we want to start there by being able to repair it after it happens. So that's number one, or number two. Number three, I think we now, because we have testing and awareness and access, we can actually do studies of patients, both to understand how the disease happens and also to intervene. So let me give you an example. Now, people are aware if I have a cold and I have injury to my sense of smell and it doesn't come back in a few weeks or a month, I can be seen, I should be seen, I could be injury to the nerve. So people will come in earlier. And one problem we've had in studying interventions and even the injury is that we get a mixture of people. Some people, I've had smell loss for 2 years. I had the cold 2 years ago. Some people, it was 6 months. Some people, it was 5 years. Some people, it was 10 years. We had this sort of heterogeneity of when people come in. And now we can do studies where we look for people and say, hey, if you have you had smell loss in the last 3 months, come in. And you can
Mhm.
actually get people because people are aware of what's going on.
Yeah.
And so the
Mhm.
ability to, for example, collect mucus from the nose, to look inside in the olfactory cleft, to collect, even to potentially collect cells, to ask questions at the time, to look for viruses where we couldn't look before. We have that ability now. And so I think that's going to lead to more information about what's going on, the natural history, but also more information on more of the ability to test people. Because so now, and finally, there are companies, there are uh, drugs being repurposed, new drugs that are available to test, and we can actually bring the people in and put people in trials and actually test those drugs, right? But whereas before, I don't think we had that ability, that sort of awareness enough where we could get enough people. And that's, I think, the problem in the field that you see. You see there are treatments and you see small scale studies, but they're not big enough to where we can really see a big difference or gain enough information to know how the physiology is working. So you'll see small trials of like, 10 or 15 people, 20 people, but they have this mixture and you see mixed results. And we don't have enough power to actually identify the things that work. And I think we will in the future. And so that's what I think about the state of the field here. This is my sort of opinion. I'm a population health researcher and I study humans, and because I think that's the organism of interest. And other people, what's exciting and difficult about this field is you have all the people who are studying insects and animal models like mice, and you have other people studying individual olfactory neurons, whether they be human or other. And we have to all put ourselves together to look at this problem from all the different angles to
Mhm.
develop new therapies in the future.
Absolutely. Thank you. That was a great response. I do want to talk about the Sense Network. So I attended the virtual meeting. I think that was November, October of last year. It was a great meeting online and it was also in person. So that was cool. Can you talk more about the Sense Network, how it came about, and how it's focusing on all the different sensory issues. And specifically, we talked about smell dysfunction and aging. So I know the Sense Network has a focus on aging. So can you kind of give us more of a rundown about what the work entails?
Yeah, so there's a wonderful community of people, researchers, who were very interested in sensory aging. And different people were doing different aspects of sensory aging. We had colleagues who were working on hearing and aging. We had colleagues who were working on vision and aging. I was working, and other colleagues were working on olfaction and aging. Um, and we came together and said, like, hey, we all find these same kinds of things. We all find that it's involved in really affects people in their daily lives. We all find that these different modalities all affect brain function, are very closely tied to dementia. We all think about what could we do to intervene and have people have better sensory function. And we realize that some of these relationships and disease associations are similar. There are stem cells in the ear and stem cells in the eye, and could we use those ideas to kind of develop new therapies? So two colleagues, Josh Ehrlich, who's an ophthalmologist who studies vision at Michigan, and Jennifer Deal, who's an expert in hearing research at Johns Hopkins, came together and formed the network. And we actually started the network with nothing. So it was just a bunch of us had some meetings online, tried to get some lectures together, tried to form a community, try to connect people. And we found this opportunity to use that platform that we had developed really just with, some sticky tape and, some staples, like sort of
Yeah.
packed together. And they wrote an application to the National Institute on Aging. Could we build a network that was focused on sensory aging, and tackle all the senses together and kind of put our expertise together so that we could learn more from each other, stimulate new research, stimulate new treatments, incorporate patient experience, and lastly, train a new generation of people. So we're all a little older, and we want to train new people to attack this problem. It's a big problem,
Hmm.
and so we were able to get this funding for this network. The network brings people together for research. It brings people together for ideas and collaboration. We have online webinars where we have different speakers from around the world. It's an international network. We make the times so it works for Europe, and we try to make it so it works for Asia. It's quite complicated. We have some at 11 o'clock in the morning. We have some at 4 o'clock in the evening. We try to like accommodate as many people as possible. And it's really open to anybody who's interested in sensory function. So we cover all five senses. We'll cover, additional things. And it's really multidisciplinary. I would say it's mostly focused on human research rather than basic science. There is some basic science in there, but it's application to humans. There's a lot of population health and epidemiology. We had one meeting, which I think you attended virtually, and another colleague from STANA attended in person, which was
Yep.
wonderful. And we actually had some patient discussion with patients with different forms of sensory loss, including olfactory loss, and to speak at the conference to really, give their perspective and their ideas. We had some research topics. We had some breakout sessions for people like, hey, what are the problems in the field? And we are going to publish a paper on like what did we find from these experts who are at this conference? What
Mhm.
did we incorporate from patients? What are our priorities? What are some low-hanging fruit that we can tackle together
Yep.
that could cross-fertilize? And then we are writing a paper on that conference about their ideas and another paper from an expert panel, sort of scientific priorities in the field. We'll be publishing those two papers. And then we are planning on additional meetings. So we were planning in the future to have a World Congress of Sensory Function, where we bring
Nice.
all these people together and other people to really talk about these ideas and how can we can operationalize them. So we are building this network as a platform for sensory research. Olfaction will be a big part of it. And I think by banding together with colleagues from other senses, we'll learn more and be able to have a bigger impact in the field.
Absolutely. It's great. I'm so excited for the work that you guys are doing. And obviously the connection on aging is important because we all get older.
That's
Every
right.
day we're getting older. So it definitely affects everyone. So thank you for that work.
Yeah, and
Um,
I'll say not only aging, but it will incorporate other things too. So we're even though it's an aging network and we aging is a big focus, we are thinking about the context of sensory function in a bigger way. We have a nice website. There's a lot of content there, sensenetwork.org. People can find us, they can reach out to us, and we're happy to involve everybody who's interested.
Thank you. That's great. Do you have any final thoughts you'd like to share regarding Anosmia Awareness Day or anything else before we wrap up?
Well, I'm sad that we have to have an Anosmia Awareness Day. I know the impact it really has on people, but I think the more people we can make aware about this problem, the more likely we are to be able to fix it in all the different ways we talked about today. And again, I'm optimistic because I think this is an area where we now have a lot of interest. and a lot of focus, and a lot of people who are dedicated. And so I think we have a bright future. I think my other thought is that, STANA is a wonderful example of people being organized to help other people with a problem that they have. And so I think STANA is a really great partner for a lot of the different research conferences and networks and meetings that I've been to, which has really made it a more rich environment to tackle these big problems. So I applaud you for that for sure.
Thank you. Yeah, we like to insert ourselves all over the place to
Great.
represent the patient voice. So, yeah, thank you for saying that. So, Dr. Pinto, thank you for sharing your expertise and the work that you're doing to advance understanding and care for people who are experiencing these types of smell disorders. I feel like conversations like this are just so important because for many people, smell loss is invisible, it's misunderstood, and it's often overlooked in healthcare. So, to everyone who's watching, if you found this discussion helpful and you would like to see more conversations with leading experts, please consider supporting STANA and our work. You can donate on our website at www.thestana.org. And in recognition of Anosmia Awareness Day, we encourage you to share this video to help raise awareness and ensure that no one living with smell loss feels alone. And Dr. Pinto's hopeful, so we should all be hopeful. So thank you for joining us, and we look forward to continuing the conversation about sensory health together.
Thank you for having me.